Vera, and this is the part 2 of the series of 2 lectures regarding integrated management of childhood illnesses. This follows the module on 2 months to 5 years old, and now we'll be talking about sick young infants aged up to 2 months. So from birth to 2 months, then we learn how to classify, assess, and classify the sick young infant. This is all based on the Pedia file that was released by WHO. Several objectives. First is generally is to learn how to manage a sick infant up to 6 months old. Rapid assessment of the sick infants, identifying danger signs of very severe disease, which is very important. Signs of bacterial infections, jaundice, and diarrhea. Assess for HIV infections, to assess the feeding problems and weight issues, to learn how to assess the level of immunization and vitamin A status, and to identify treatments for the child's infant's classifications and deciding if the infant needs to be referred. Provide treatments in the health center such as oral rehydration therapy, vitamin A, and immunization, giving important pre-referral treatment and referring the infant, counseling the mother about feeding care for the development and when to return, and last would be reassessing the problem and providing appropriate care when an infant comes to the scheduled follow-up. Okay, so we start with assess. Once presented with an infant, do a rapid appraisal of all waiting infants. So you need to see them, eyeball, rapid, ask the mothers what are the young infant's problems are. Determine if this is an initial or follow-up visit for this problem. If follow-up visit, use the follow-up instructions. If initial visit, then assess the young infant. You ask, is the infant having difficulty feeding? Has the infant had convulsion or fits? Okay. Look, listen, and feel. Count the breaths in 1 minute. Repeat the count if more than 60 breaths per minute. Hopefully, you can still remember what you have learned regarding fast breathing in the first module. Look for severe chest indrawing. So, in all of this, you must look, listen, and feel when the infant is calm. So, the infant must be calm. Look, listen, and feel for axillary temperature. You measure it. Look at the umbilicus. Will there be a problem? Is it red or draining pus? Look for skin pustules. Look at the young infant's movements. They should all be moving. All extremities should be moving actively, and there is nothing. No extremity should be lagging behind. If infant is sleeping, ask the mother to wake him or her. Does the infant move on his or her own? If the young infant is not moving, just gently stimulate him or her. Then, does the infant not move at all? If, in spite of your stimulation, in spite the mother is waking her child, and still the infant is not moving, then there is a problem. Okay, so you classify them again, like in the IMCI 1, you classify it to 3 rows: the pink, the yellow, and the green. The pink is the danger signs. So any of the following signs that may manifest as very severe disease: not feeding well, or convulsions, or fast breathing 60 breaths per minute, or there is the presence of severe chest indrawing, or there's fever which is 37.5 degrees or above, axillary temperature, or the opposite, has low body temperature which is less than 35.5, or movement only when stimulated, or no movement at all. So this is classified as very severe disease. So what you do, give the first dose of your intramuscular antibiotics, treat to prevent low blood sugar, refer urgently to the hospital, then advise the mother how to keep the infant warm. This is very important. Thermoregulation is very important for infants on the way to the hospital. So before you send the patient to the hospital, give your initial IM antibiotics. Hopefully you can determine low your blood sugar. If not, just give sugar water or breast milk. You can do it, OGT if necessary to and feed the infant if ever you can. You start your IV therapy using dextrose containing fluids before referring the child to the hospital. And of course, it's very important for infants, thermoregulation. So you must always advise the mother to keep the infant warm on the way to the hospital. For yellow, if there's no problem that may show danger signs, then look at the umbilicus. Is it red or draining fast, or would there be skin pustules? Hopefully you know what pustule is. So that it can be classified as a local bacterial infection. Then you give your appropriate oral antibiotics. Teach the mother to treat the local infection at home. Advise the mother to give home care for the young infant, and you ask her to follow up within 2 days or in 2 days. However, if the patient will be classified under the green or severe disease or local infection, unlikely. So there is none of the signs of very severe disease or local infection, then advise the mother to give home care. Again, for jaundice, if jaundice is present, ask, when did the jaundice first appear? Look and feel. Look for jaundice, especially look at the sclerae, yellow of the eyes or skin. Look at the young infant's palm and soles. Are they yellow? Okay. Again, you classify it into 3 categories: the pink, yellow, or green. The pink for severe jaundice, and the jaundice if age is less than 24 hours, meaning the jaundice appeared at birth. Yellow palms and soles at any age. Okay, that would be labeled as a severe jaundice. Then treat to prevent low blood sugar. It's very important. Then refer urgently to the hospital. Advise the mother how to keep the infant warm on the way to the hospital. Okay. Then the jaundice is appearing after 24 hours of age, and the palm soles are not yellow. So this is just jaundice, labeled as just jaundice. Advise the mother to give home care for the young infant. Advise mother to return immediately if palms and soles appear yellow. If the young infant is older than 14 days, refer to a hospital for assessment. Follow up in a day. If no jaundice, that is classified as no jaundice, advise the mother to give home care for the young infant. Then ask, does the young infant have diarrhea? If yes, look and feel. Look at the young infant's general condition. Look at the infant's movement. Does the infant move on his or her own? Does the infant not move even when stimulated but then stops? Does the infant not move at all? Is the infant restless and irritable? Look for sunken eyes. Is the skin on the abdomen, does it go back very slowly, longer than 2 seconds, or slowly? So you classify it to the pink row as severe dehydration with the two of the following signs: movement only when stimulated or no movement at all, in the background of diarrhea. Sunken eyes, skin pinch goes back very slowly. If the infant has no other severe classification, give fluids for severe dehydration, meaning you use your treatment plan C. Or if the infant has another severe classification, refer urgently to the hospital with mother giving frequent sips of ORS on the way. Advise the mother to continue breastfeeding. For the yellow row, two of the following signs: restless and irritable, sunken eyes, skin pinch goes back slowly, so that is classified as some dehydration. So give fluid and breast milk for some dehydration, that is your treatment plan B. If the infant has severe classification, refer urgently to the hospital with mother giving frequent sips of ORS on the way, and advise continuous breastfeeding. Advise the mother when to return immediately or follow up in 2 days if not improving. Not enough signs to classify as some or severe dehydration, then you classify it in the green row as no dehydration. Just give fluids to treat diarrhea at home and continue breastfeeding as in treatment plan A. Advise mother when to return immediately. Follow up in 2 days if not improving. Check now for HIV infection. Ask, has the mother and the young infant had an HIV test? If yes, what is the mother's HIV status? Is the serological test positive or negative? What is the young infant's HIV status? Is a virological test positive or negative, or is the serological test positive or negative? If the mother is HIV positive and no positive virological test, the child asks, is the young infant breastfeeding now? Was the young infant breastfeeding at the time of the test or before it? Is the mother and the young infant on PMTCT ARV prophylaxis? If no, test the mother and the young infant status is unknown. Perform HIV test for the mother. If positive, perform virological test on the young infant. Then you classify them into whether confirmed HIV infection, HIV exposed, or HIV infection unlikely. So a positive virological test in the young infant means it is a confirmed HIV infection. So you give cotrimoxazole as prophylaxis from 4 to 6 weeks. Give HIV ART and care. Advise the mother on home care. Follow up regularly as per national guidelines. If the mother is HIV positive and a negative virological test in the young infant, and the young infant is breastfeeding, or if only stopped less than 6 weeks ago, or mother is HIV positive and the young infant is not yet tested, or positive serological test in the young infant, then you label it as classify it as an HIV exposed. So still for the management, you give your cotrimoxazole prophylaxis for 4 to 6 weeks. Start or continue your PMTCT ARV prophylaxis as per national recommendations. Do virological test. Okay. At age 4 to 6 weeks, or repeat 6 weeks after the child stopped breastfeeding. Advise the mother on home care and follow up regularly as per national guidelines. For those infant negative HIV tests in mother or young infant, then it is HIV infection unlikely. Treat and counsel and follow up existing infections. Check for feeding problems or low weight for age. In an infant, there's no indication to refer urgently to the hospital. Okay, ask, is the infant breastfed? If yes, how many times in 24 hours? Does the infant usually receive any food or drinks? If yes, how often? If yes, what do you use to feed the infant? Then look, listen, and feel. Determine the weight for age. Look for ulcers or white patches in the mouth. It's called your oral thrush or oral candidiasis. Then you assess for breastfeeding. Has the infant breastfed in previous hour? Is the infant has not fed in the previous hour, as the mother to put her infant to the breast. Observe the breastfeed for 4 minutes. If the infant was fed during the last hour, ask the mother if she can wait and tell you when the infant is willing to feed again. If the infant is well attached, not well attached, or good attachment, so you look for it. To check for attachment, look for in this one. You have to understand this one. To check for the attachment of the infant to the breast, okay? The chin should be touching the breast. The mouth is wide open. The lower lip is turned outwards. More areola visible above than below the mouth. All of these signs should be present so that you can label the attachments as good. If the infant suckling effectively, that is, it only shows slow deep sucks, sometimes pausing, or not suckling effectively, or suckling effectively. Please note if there's a clear or black nose, because it can interfere with breastfeeding. Okay, then Classify it either with feeding problems or low weight or no feeding problem. For the feeding problem or low weight, these are looked for, classify: not well attached the breast, or not suckling effectively, or less than 8 breastfeeds in 24 hours, or receives other foods or drinks, or low weight for age, or thrush, ulcers or white patches in the mouth. Okay, what do we do? If not well attached or not suckling effectively, then teach. Okay, teach the correct position and attachment. If not able to attach well immediately, then teach the mother to express breast milk and feed by a cup. If breastfeeding less than 8 times in 24 hours, then advise the mother to increase frequency of feeding. Advise the mother to breastfeed as often as long as the infant wants, day and night. If receiving other foods like or drinks, counsel the mother about breastfeeding more, reducing other foods or drinks, and using a cup. If not breastfeeding at all, refer for breastfeeding counseling and possible relactation. Advise mother about correctly preparing breast milk substitute and using a cup. Advise the mother on how to feed and keep the low-weight infant warm at home. If there is thrush, teach the mother to treat thrush at home. Advise the mother to give home care for the young infant. Follow up any feeding problem or thrush in 2 days. Follow up low weight for age in 14 days. For those without feeding problems, then no low weight for age and no other signs of inadequate feeding, then you just advise the mother to give home care for the young infant and praise the mother for feeding the infant well. Okay. For HIV-exposed infants not breastfeeding and for the infant that has no indication to refer urgently to the hospital, then ask the following question: what milk are you giving? How many times during the day and the night? That's the feeding frequencies. How much is given at each feed? How are you preparing the milk? Let the mother demonstrate or explain how a feed is prepared and how is it given to the infant. Then ask, are you giving any breast milk at all? What foods and drinks in addition to replacement feeds is given? How is the milk given? In a cup or in a bottle? How are you cleaning the feeding utensils? Then look, listen, and feel. Determine the weight for age. Look for ulcers or white patches in the mouth. That is thrush. Then you classify now as feeding problem or low weight and no feeding problem. Okay. If feeding problem low weight, then milk incorrectly or unhygienically prepared, or giving inappropriate replacement feeds, or giving insufficient replacement feeds. Meaning this one, when you give a follow-up milk formula dose and you're dealing with an infant, then you give them milk that is intended for 1 year old and above. Okay, that's your inappropriate replacement feeds. An HIV positive mother mixing breast and other feeds before 6 months, or using a bottle, or low weight for age, or thrush or ulcers of the mouth or patches in the mouth. So what do we do? Counsel about feeding, explain the guidelines for safe replacement feeding, identify concerns of the mother and family about feeding. If the mother is using a bottle, teach cup feeding. Advise the mother on how to feed and keep the low-weight infant warm at home. If there is thrush, teach the mother to treat the thrush at home. Advise the mother to give home care for the young infant and follow up any feeding problems or thrush in 2 days. Then follow up low weight for age in 14 days. Now for no feeding problem, that's it in the green row. No low weight for age and no other signs of inadequate feeding, then advise the mother to give home care for the young infant, and then praise the mother for feeding the infant well. So check the infant's immunization status and vitamin A status. In here, you give all the missed doses on this visit. Include sick infants unless being referred. Advise the caretaker when to return for the next dose. There's a note in here. Your DPT Hep B is available as a pentavalent vaccine. Okay, so in here. Okay, so this is your immunization schedule. Okay, at birth, 6 weeks, you can give your BCG and your first Hep B. At 6 weeks, now you can give your pentavalent plus OPV, your rotavirus 1, and your pneumococcal conjugate vaccine first dose. Then you can give your vitamin A, okay, 200,000 units to the mother within 6 weeks of delivery. So this is given to the mother, okay, within 6 weeks of delivery. Assess for other problems. Okay. Assess the mother's health needs, nutritional status and anemia, about contraception, check for hygienic practices, and encourage smoking cessation in the family if ever there will be. So you always have to assist there a smoker in the family. Okay. So this is the slide for treat the young infant. Okay. If ever you need to refer the patient urgently to the hospital, then give your first dose of your intramuscular antibiotics. Give the first dose of both your ampicillin and gentamicin intramuscularly. Your ampicillin is 50 mg per kilo. Your gentamicin will depend on the age of the infant. If less than 7 days, you give 5 mg per kilo. If more than 7 days, you give 7.5 mg per kilo. That's IM doses as the first dose. Then referral is the best option for the young infant if the infant is classified with very severe disease. If referral is not possible, continue to give ampicillin and gentamicin for at least 5 days. Ampicillin twice a day to infant, which is less than a week of age, and given 3 times a day for infants one or more than a week old. Then in here you also can give your gentamicin once a day. If the infant is able to breastfeed, so treat the infant to prevent low blood sugar. Okay, ask the mother to continue to breastfeed the infant. If the young infant is not able to breastfeed but is able to swallow, then you give 20 to 50 ml. That would be around equivalent to 10 ml per kilo of express breast milk for departure. If not possible to give express breast milk, give 20 to 50 ml or 10 ml per kilo of your sugar water. To make sugar water, dissolve 4 level teaspoons of sugar. That would be equivalent to 20 grams in a 200 ml cup of clean water. Okay, so that's around 10%. Okay. If the young infant is not able to swallow, give 20 to 50 ml of express breast milk or sugar water via NGT or nasogastric tube, or OGT or orogastric tube. Teach the mother how to keep the young infant warm on the way to the hospital. Provide skin-to-skin contact or keep the young infant clothed or covered as much as possible all times. Dress the young infant with extra clothing including hat, gloves, socks, and wrap the infant in a soft dry cloth and cover with a blanket. Okay. If ever you need to give an appropriate oral antibiotics for the local bacterial infection, then your first line antibiotic would be amoxicillin drops or suspension to be given twice a day for 5 days. Teach the mother to treat the local infection at home. Explain how the treatment is given. Watch her as she does the first treatment in the clinic. Then tell her to return to the clinic if the infection worsens. The mother should do the treatment twice daily for 5 days in cases of skin pustules or umbilical infection. They should wash their hands Gently wash off the pus and cast with soap and water and dry the area. Paint the skin or umbilicus or cold with full-strength Gentian violets around 0.5%, or apply mupirocin cream twice a day until it is dry, usually in 3 days. And again, after the procedure, you wash the hands. To treat thrush or ulcers or white patches in the mouth, the mother should do the treatment 4 times daily for a week. First is wash your hands, paint the mouth with half-strength Gentian violet. So the full strength is 0.5, the half strength would be 0.25%, using a soft cloth wrap around the finger. An alternate treatment to Gentian violet would be giving nystatin oral suspension at around 100,000 units per ml. Give at least 1 to 2 ml into the mouth for 7 days, then wash the hands. You counsel the mother regarding breastfeeding, teach correct positioning and attachment for breastfeeding, teach the mother how to keep the low-weight infant warm at home, teach the mother how to express breast milk, teach the mother how to feed by cup. Advise the mother to give home care for the young infant. Okay, now we will be talking about follow-up. Okay, for local bacterial infections, so you ask them to follow up after 2 days. Then on follow-up, you look at the umbilicus again, if it is red or draining pus, or look for the presence of skin pustules. So we treat if the umbilical pus or redness remains the same or is worse, then refer the patient to the hospital. If the pus and redness are improved, then tell the mother to continue giving the 5 days of antibiotic and continue treating the local infection at home. If skin pustures are the same or worse, then refer the patient to the hospital. However, if it improves, tell the mother to continue giving the 5 days of antibiotic and continue treating the local infection at home. Now, follow-up care for diarrhea. So after 2 days, you ask, has the diarrhea stopped? Then, if the diarrhea has not stopped, then assess and treat the infant according to their classification. Okay. If the diarrhea has stopped, tell the mother to continue exclusive breastfeeding. And jaundice. Okay, after a day, so you ask them daily follow-up. Look for jaundice. Are the palms and sole now yellow? So if the palms and sole are yellow, refer to the hospital. However, if the palms and soles are not yellow, but jaundice has not decreased, advise the mother for home care and ask her to return and follow up in a day. If the jaundice has started decreasing, then reassure the mother and ask her to continue home care. Ask her to return to follow up at 2 weeks of age. If the jaundice continues beyond 2 weeks of age, then refer the infant to a hospital for further assessment. Follow for feeding problems. After 2 days, reassess the feeding. Then ask about any feeding problems found on the initial visit. Then counsel the mother about any new continuing feeding problem. If you counsel the mother to make significant changes in feeding, ask her to bring the young infant back again. If the young infant is low weight for age, ask the mother to return 14 days of this follow-up visit. Then continue follow-up until the infant is gaining weight well. However, there's an exception. However, if you do not think that feeding will improve, or if the young infant has lost weight, then by no means refer the child to the hospital. Follow-up of low weight for age. Then you ask the patient to follow up after 14 days. Then on consult, you weigh the infant and determine if the infant is still low weight for age. Then reassess your feeding. If the infant is no longer low weight for age, then praise the mother and encourage her to continue. If the infant is still low weight for age but is feeding well, still praise the mother. Ask her to have her infant weigh again within 2 weeks or when she returns for immunization, whichever would be early. Okay, for low weight for age, if the infant is still low weight for age and still has a feeding problem, counsel the mother about the feeding problem. Ask the mother to return again in 14 days or when she returns for immunization, if this is within 14 days. Continue to see the young infant every few weeks until the young infant is feeding well and gaining weight regularly and is no longer low weight for age. Exception: if you think that feeding will not improve or if the young infant has lost weight, then refer the infant to the hospital. Now, because here are just few slides now, we'll be dealing about skin problems. Okay, so skin problems, if there is itching rash with small papules and scratch marks, dark spots with pale centers, it is classified as papular itching rash or otherwise called your prurigo. So how you treat the itching using calamine lotion. Give oral antihistamines. If it does not improve, treat with 1% hydrocortisone cream, and can be just be careful because this can be an early sign of HIV and needs assessment for HIV. So unique features in an HIV with this case is a clinical stage 2 defining case. Okay. For the next lesion, so there's like it's like a ringworm. There's a itchy circular lesion with a raised edge. This is the raised edge, and the scaly area in the center with loss of hair may also be found on body or web of the feet. So this is classified as your ringworm or tinea. So what we can give is give a Whitfield or antifungal ointment if there's few patches. However, if the patches are extensive, refer. If not, give oral ketoconazole. If 2 to 12 months old, you give 10 to 6 to 10, around 6 to 10 kilogram, you give around 40 milligrams per day. For a child 12 months up to 5 years old, you give 60 milligrams per day or give cresofilvin at 10 milligrams per kilo per day. If in the hair, shave the hair, then treat the itching as instructed above. Okay. For this lesion, this is a rash and excoriation on the torso, burrows in the web space and wrist and face spared. This is the common site for scabies. So what do you do? To treat the itching as above, manage with anti-scabies like using 25% topical benzyl benzoate at night. Then repeat for 3 days after washing. 1% lindane cream or lotion once wash off after 12 hours. So with the first two infection, the ringworm and the scabies, for the unique features in HIV, for the ringworm, if it is extensive, there is a high incidence of coexisting net infection, which has to be treated adequately to prevent recurrence of the tinea infection of the skin. Fungal nail infection is a clinical stage 2 defining disease. For the scabies, in HIV-positive individuals, scabies may manifest as crust scabies. Crusted scabies presents as extensive areas of crusting mainly on the scalp, face and back, feet. Patients may not complain of itching. The scabies will be teeming with mites. This is the next slide. Okay. So this is a case of a vesicles all over the body, with vesicles appear progressively over days and forms scalds after they rupture. This is a case of varicella or chickenpox. So we treat itching as mentioned earlier, then refer urgently to the hospital if the patient develops pneumonia or jaundice will appear. So for unique features in HIV, this presentation is atypical only if the child is immunocompromised. The duration of disease will be longer, complications more frequent, chronic infections with continued appearance of the new lesions for more than a month. Typical vesicles evolve into non-healing ulcers that becomes necrotic, crusted, and hyperkeratotic. The next lesion is a vesicles in one area on one side of the body with intense pain or scar plus shooting pain. This is your herpes zoster, which is uncommon in children except when they are immunocompromised, for example in cases of HIV. So this is herpes zoster. So if you can see, it follows one dermatome. Okay. So what do we do? Keep lesions clean and dry. Use local antiseptics. However, if the eye is involved, give acyclovir 20 milligrams. Okay, 4 times per kilo, 4 times a day for 5 days. Give pain relief and follow up in 7 days. So for HIV, the duration of disease will be longer. There could be hemorrhagic vesicles and necrotic ulcerations. Rarely recurrent, disseminated, or multi-dermatomal. It is a clinical stage 2 defining disease. Okay, next would be a lesions around the mouth. It's red, tender, warm, crusting, or small lesions. This is called your impetigo, or it can be your folliculitis. Okay, so clean the areas with antiseptic. Drain pus if fluctuant. Start your cloxacillin if size is more than 4 cm, or red streaks or tender nodes or multiple abscesses which is present for 5 days. So you give your cloxacillin at 25 to 50 milligrams per kilo every 6 hours. Then refer urgently if the child has fever and or infection extends towards the muscles. Now here's another, these are the non-itchy lesions. Okay, so the first picture shows in there. Okay, these are sin-colored pearly white papules with central umbilications. So you know, white papules, pearly with central umbilications. It is most commonly seen on the face and trunk in children. This is your molluscum contagiosum. So it can be treated by various modalities, or you can leave them alone unless it is super infected, because these are usually self-limiting. Then you can use phenol or pricking each lesion with a needle or sharpened orange stick and dabbing the lesion with phenol, or you can do electrodesiccation, okay, or liquid nitrogen application using orange stick, or you can do curettage, or you can do nothing, just wait for it to resolve. However, a unique feature in HIV, the presence of molluscum the incidence can be higher. Okay, giant molluscum can be seen, meaning can measure up to more than 1 centimeter in size. For coalesce, there could be double or triple lesions may be seen, or more than 100 lesions may be seen. Lesions often will be chronic and difficult to eradicate. Usually, there will be extensive molluscum contagiosum, okay, which is a clinical stage 2 defining disease. Next would be your warts. The common wart appears as papules or nodules with rough verrucal, surface. So we treat with topical salicylic acid preparation like your duofilm, or liquid nitrogen therapy or electrocautery. So for unique features in HIV, the lesions will be more and numerous, and it can be recalcitrant to therapy. There will be extensive viral warts, which is a clinical stage 2 defining disease. The third would be seborrhea. These are greasy scales and redness in the central face and body folds. Then you can use your ketoconazole shampoo. If severe, then refer or provide topical steroids. For seborrheic dermatitis, you can use 1% hydrocortisone twice a day. If severe, then refer that case to the hospital. So unique features in HIV. Seborrheic dermatitis may be severe in HIV infection, and secondary infection among HIV patients may be common. I think this will be the last slide with pictures. So these are the slides that shows us the drug and allergic reactions. So there are these three. The first would be your fixed drug reaction, and it will show us a generalized red, widespread with small bumps or blisters, or one or more dark skin areas. These are your fixed drug reactions. How do we treat it? You stop the medication, give oral antihistamines. If there's a peeling rash, then refer. Unique features in ARVs. These drug reactions can be present as a sign of reaction to your ARVs. The next would be your wet oozing sores or excoriated thick patches. This is a sign of your eczema. Then what do? You soak the sores with clean water to remove scratch, but please do not use soap. Dry skin gently. Use a topical steroid in a short time, but do not use it on the face. Then give anti-itch prep medication. And the last would be your Stevens-Johnson syndrome. This is a severe reaction due to cotrimoxazole or your NVP involving the skin as well as the eyes and the mouth. Might cause difficulty in breathing. So what do? We stop the medication right away and refer the patient urgently to the hospital. The unique feature in HIV for your Stevens-Johnson is that most lethal reaction to your NVP, your cotrimoxazole, or even your efavirenz. And your IMCI 2, maraming salamat po. And again, please always visit my YouTube channel. Click subscribe and click that bell, that notification table, and please you can share this lecture so that others may learn. Thank you very much.